Leeds, and also Liverpool. His MD degree was in Leeds, and that was on the photodynamic therapy of pituitary adenomas. And he also completed the scalp-based fellowship under Dr. Gentili in Leeds, and that was on the photodynamic therapy of pituitary adenomas. I think we need to try and ask everybody to mute their microphones. Ahmed, is that something you can do you think?
It's okay now.
So that part, okay. In 2001, Dr. Kouroulos was appointed as a consultant neurosurgeon at Cambridge Hospitals, and where he stayed until June 2018. His main clinical interests are cerebrovascular surgery, skull base, pituitary and pineal surgery, as well as surgical treatment of AVMs, which is the topic of today's talk. In the past, he was the president of the British Neurovascular Group and president and co-founder of the British Irish Meningioma Society, and a member of several other committees in the ENS and WFNS. But importantly, he was also the co-founder and co-director of the Cambridge Lectures in Neurosurgical Anatomy. And in fact, he has been a great anatomy teacher, and he believes in the major role that neurosurgical anatomy has to play in the safe planning of neurosurgical operations. So without further ado, I would like to ask Mr. Kouroulos to start with his talk, and shortly we'll move on to the PowerPoint. Thank you very much. In the end, Mr. Kouroulos will take some questions from the audience, or questions that may have been mentioned on the chat. Okay, thank you.
Thank you both. Now we will go for a presentation, then we will receive the question at the end.
Okay. Start in PowerPoint.
Greetings, everyone. This is a surgical planning talk based on anatomy for AVMs. The aim is to convert radiographic and angiographic anatomy and be able to convert it into a 3D operative visualization so that you can estimate the task you are going to face and preoperatively have a mental planning of each step, exact details. As such, we should execute the surgery with the simplest technical maneuvers and minimize the resulting neural injury. In this talk, I'm covering these points mainly on anatomical planning, pitfalls, and a little bit on what to do when you are faced with a large intracranial hematoma secondary to an AVM rupture. But this is not a talk on clinical indications or epidemiology or basic science of AVMs. And in particular, it is not a technical talk on microneurosurgery. So surgical planning for AVMs is aimed to achieve the two goals, which are namely, number one, total resection of the lesion. As there is no halfway, as you proceed, there is no return. And second, to minimize the morbidity, as really in neurosurgery, morbidity or the price of surgery realistically cannot be totally eliminated, so that to try to minimize it at least. This talk is predominantly concerning the use of thorough neuroanatomical knowledge to plan resecting AVMs with minimal brain injury, and particularly with simplifying the technical aspects. But first, let's briefly discuss how to anticipate and estimate the task to achieve goal number one, which is total resection. The existing scales that you all know of Spetzler-Martin or its modification, Spetzler-Pons, and Lawton-Young, they help to estimate the task before embarking into surgery. You all know it takes into account items such as size, deep venous drainage, eloquence, most importantly in the last classification, how the nidus can be defined, as it's more difficult usually when there is a diffuse nidus that you cannot define easily, and also whether there is a previous hemorrhage that provided you an easy gliotic plane, and also age will have a role. These are all good for this purpose, but in addition, look at the location of the nidus and estimate the difficulty to access the nidus and the feeding vessels through the possible surgical corridors and trajectories. To minimize morbidity, let's look at the causes of that. This could be related to cortical injury from your approach and trajectory, and also from the section of the nidus. It could be vascular in origin by, for example, obliterating an on-passage vessel to important functional region, or even venous injury. But what has been underestimated, despite its utmost importance, is the disruption of important adjacent white matter tracts. It is inevitable that deep extension of the nidus, when large enough, will be in juxtaposition to these white matter tracts. If these are not already disrupting some fibers, then the surgery can disrupt more. Although the category eloquence in the special origin classification refers to cortical regions, and in fact, some deep structure like here, the dentate nucleus in the cerebellum, in fact, plasticity can recover cortical injuries, but white matter tract disruption is likely to result in permanent deficits. So look at each case and perform a mental execution of all the operative steps before you actually operate. Of course, we exclude the cases of simple AVMs, which in fact should be by far constituting the majority of your practice. But you must be able to perform the whole procedure to the exact details in your mind in the at least a day in advance of your scheduled surgery. At surgery, you proceed only when you see matches what you already visualized in your head in advance. Once you establish the clinical indication to operate, which of course without saying is by far the crucial step, this is not the scope of this talk. So you then look at the structure of the AVM and decide whether or not you will be able to take it to surgery. In my opinion, the recurrent pitfalls are either underestimation of the task or conversely overestimation. As there is usually a point of no return during surgery, it is quite obvious that underestimation before you start is going to lead to a disaster if you cannot safely complete the task. On the other hand, overestimation potentially can deny offering surgery or lead to unnecessary complicated planning with more and more complex technical steps, and all have potential harms. This is again reasons of difficult to estimate the task, because you can have some cases where it's difficult to define the nidus, as there is some perinidal changes that really are not part of the nidus that are difficult to identify intraoperatively. But again, remember, simple AVMs needs simple surgery. These talks are mainly regarding planning more demanding AVMs. This brings us now to the main message of the talk, which is how you can make sense of seemingly a complex structure such an AVM using neuroanatomical knowledge to interpret the investigations. In other words, making order out of chaos or seeming chaos. I have deliberately eliminated from my discussion the relatively more complex lesions that I performed from this talk, as these have no educational value whatsoever, and they just serve to show off some skilled surgeons. But I shall include relatively complex anatomical discussion from now on. However, do not worry if it seems incomprehensible at the start or in the first glance, as I shall keep repeating certain points, and hopefully by the end, it will become clearer. So we look at the investigations that we have, and we try to understand and simplify the structural anatomy we see, but also be mindful of what potential morbidity we can cause. We have to plan that before even you take on the case and before you operate on. So the two modalities we use for investigation is MRI scans. And by the way, the photograph here is from Aberdeen, where it shows the original, the first ever MRI in the world. It is housed there for demonstration. So when we look at the MRI is good in some aspects, but not so good in others. For example, the size, because it does not really estimate perinidal changes. You cannot use, or veins, you see such flow voids, but it does not tell you the exact size of the nidus, which in difficult cases can not be enough even to plan or to refer patients to stereotactic radiosurgery. But it's very good to show you the cortical location of the AVM. It can show extension towards the ventricle, the periventricular extension. It can show white knotted tracts, even better if you can perform DTI or tractography. And from anatomical knowledge, it will tell you the eloquent area of the brain, but this is on anatomical basis. Again, although it does not tell you where exactly the feeders are, but it can predict it, but because you know each part of the brain is fed by certain feeders. And similarly, you know which surface of the brain drain where, so you can predict possible venous arrangements. Function is only anatomical, and don't rely on functional MRI because the principles behind it is a bold signal. You have already disturbed blood flow around the nidus, so it is not reliable. But MRI scan cannot tell you anything about the flow dynamics, whether it's a high flow fistula or not. The nidus architecture, because it shows you just flow voids. Some of them are just dilated draining veins. And as I mentioned before, perinidal changes. The other investigations that unfortunately neurosurgeons have lost some of the skills in looking at, which are angiograms. Now, the neuroradiologist can grade your angiograms, and they will include in the reports the size of the nidus, the location of the nidus, whether it's cortical or deep. Sometimes they look at the feeding vessels and can predict its lobar or cortical location. And this is a very important skill that neurosurgeon needs to become familiar with. It is very good to tell you whether the nidus is compact or diffuse, and most importantly, the pattern of venous drainage. But as a surgeon, you need more information that the neuroradiologist may underappreciate that we require during our surgery. They tell you the feeders, their origin, their number, but again, you have to understand where will you find them in relation to the sulci and gyri of the surface of the brain. And you can predict some areas in particular that are more prone to important en passant vessels, such as the distal posterior cerebral, when some of the distal branches of the PCA goes to the primary visual cortex. So you have to be particularly careful in this location. Don't forget that AVMs can have compartments, be aware of. They can be fed by different vascular territories and have different draining veins. You have to look at the perineidal vessels or be aware that in some AVMs they are more prominent than others. The transient time or the flow, how quickly the venous phase appear, will tell you whether it's a high flow fistula with some anticipated operative difficulty. And at the end, in your mind, you have to look at a sphere that has multiple poles and main arteries and veins entering to that and establish the arterial and venous pole of the malformation. So this is require how you look at the angiogram dynamically and form in your mind a picture of the nidus with different vessels going into different locations. So you can see here in the diagram, there are 3 poles, 1 venous and 2 arterial. And the arrangements, they are not overlapping. Perhaps you don't see the deep part of it, but a deep part will have other deep perforator. And there are programs all over the place now, commercial, that shows you virtual reality 3D rotational models, and they will rotate it for you, and they are quite good for planning. This may not be enough, because what you require is not just to rotate the nidus of the AVM and the vessels, but during the rotation, you have to be aware how the brain, cortex, and deep structures are rotating with this model, because it is not an isolated operation on vessels. The AVMs are embedded within the substance of the brain, and you have to have in your mind a mental 3D virtual reality rotation model that includes the nidus, the distal vessels, and the brain structure itself. This requires that you have skills that allow you dynamic visualization of the angiogram. I will come back to this point in a later slide, but when you look at the angiogram, you are not a neuroradiologist. As a surgeon, you have in your mind, how would you achieve the venous exposure? What is the arteriovenous relationship? Was there some veins overlapping arteries? Where are the arteries entering? Which poles predominantly? How would you access the feeders? How do you expose them? And at which stage? For example, if a vein is obscuring a main feeder, then you cannot disrupt the vein to reach that. So you may choose to attack this feeder at a later stage. You have to look at the nidus, establish what is the eloquent relationship, not only to the cortex, but to the deep white matter tracts, whether the nidus have a deep extension, even going towards the ventricle. And look at the angiogram to predict whether you'll have difficulty from perineidal vessels or different compartments. So in summary, these investigations are complementary. From the MRI, you look at the location and you can predict, each part of the brain has predictable blood supply. Like this is no doubt is coming from the middle cerebral artery, but which branch, then we will establish that a bit later. You can look at the angiogram, even from the AP, which are you're not used to. This is an MCA projection, and you can tell that the predominant vessels are the pre-rolandic and rolandic arteries, but I will go into that later. The most important fact is included in this slide, because AVMs can look so much complex, everything look abnormal to you. But in fact, AVMs are a malformation or fistula connection in the capillary vascular bed. What does that mean? That it means that every feeding artery and draining vein are normal anatomical location. They may not be normal structures, they may be dilated or look bizarre, but in fact, they are in normal location. Of course, there are human variations normally, but in AVMs, every feeding artery and vein are predictable. They are in normal humans. So this fact will tell you that it's most important that you know your vascular anatomy, and that will help you in making AVM surgery much easier and to interpret investigation more efficiently. So this is the vascular arrangements. Now, as neurosurgeons doing aneurysms and skull-base surgeons, we are very familiar with the pattern of the arteries. You can recognize them in the cisternal portions. This is a major circle of Willis branches. They travel within sulci, so the sulcal arrangements, and then on the cortex. However, when they become more and more distal, you need to know the anatomy of the distal vessels. Of course, there are variation and anastomosis, but some of them, there are constant features. Now the question, what is perforators? In fact, all vessels will eventually perforate the cortex and go to the subcortical structures. So the distal ACA, MCA cortical branches will perforate the cortex and they will supply a subcortical AVM. These subcortical vessels, although normally you don't see them, they are present. As I said, AVMs do not invent new arteries. These are the arteries that is there already. However, they are much more dilated. But also there are the true, what is called true perforators, such as the lenticular striate, the recurrent artery of Hübner, the thalamoperforators, and so on. They are end arteries, and they end in important structures. But again, a lot of them you may not see. They continue to supply other parts of the brain, but we don't see them. Sometimes they become dilated. The lenticular striate vessels do not just stop in the internal capsule. They continue through the corona radiata. We don't trace them there normally, but if you have a nidus deep there, they will become dilated and more obvious. And then important because of the ventricular extension to know the anatomy of the choroidal and subependymal vessels that supply the choroid fissure and the choroid plexus. The arrangements of the arteries and the veins in the brain is variable to the rest of the body, where you have an axillary artery and axillary vein with it, a femoral artery and a femoral vein. Now in the brain, not always that the arteries and the vein on the cortex are in intimate relationship, but in some areas they are. So it is very common at the end of dissecting a nidus, leaving only the vein, and you look at the nidus and it's still filling, because normally there is still a persistent feeder stuck to the adventitia of your draining vein, because this is an area where an artery and vein are running together. So we have to be aware of these arrangements. Now the venous anatomy is very important, but it's variable. But most of the veins are important to identify because this is what appears on the surface. We are having a sulcal pattern before they go to the major venous sinuses. However, there are veins that are called transcerebral veins. These are the veins we don't normally encounter. They may become dilated. These are the veins that are draining the deep part of the nidus. And when you are resecting the nidus, you will find dilated vein in the depths of the white matter. Again, these are not new veins. These are veins that already we all have, but they are not as dilated as that. The anatomical location of these is very unpredictable, but you have to be aware of them. And then there is, again, for those AVMs drain extending into the ventricles, the subependymal veins that normally go to the deep venous system. So this is the dynamic way we look at angiogram. Most hospitals have computer systems where we look at radiology. So first, we look at the arterial phase from very early so that you trace the normal vessels. Why do you need to trace them? Because you can identify the vessels downstream from your nidus. It will tell you where are they. Even if you don't see the brain on an angiogram, it will tell you which sulcus, which cortical, how far away from the sylvian fissure, how far away from the superior frontal sulcus, and so on. Not only you need to know where they are so that you have proximal control, but also it will help you to know, especially in cases with perinidal changes, where is your limit of your nidus. So if you can identify distal, cortical, frontal, MCA branches up to the superior frontal sulcus, that means that the AVM inferior pole of the nidus is not extending towards the sylvian fissure, but will stop over there. Then you look at the venous phase in the reverse order. You go from late to early venous phase until you identify the veins that are spilling into the arterial phase, because these are your draining veins of the nidus. This is your gate that you follow that will take you to a subcortical AVM. Again, you cannot look at them in isolation because you have to get a relationship between the draining veins and the feeding arteries, because sometimes the vein is superficially overlying a main draining vein, and you should not disrupt the vein until the end. Then look at the deep extension of the nidus. This will predict if it is too deep, it will be recruiting periependymal vessels from the ventricle, or deep in the white matter, then it will be extending towards a terminal branch of true deep perforators. This is a fact that is very important, how the nidus extend. This is not a cavernoma, this is not a hemangioblastoma, it's not a tumor. So the nidus does not enlarge deeply and attached to deep vessels. In fact, why there is a deep extension or a pore, even if you don't see any feeding vessels from an angiography, is that there is a deep connection as if there are vessels pulling the nidus deep. This has implication because there is no blind poles of the AVM nidus. Everywhere it is connected to vessels. That's why they have this shape. Then finally, look at the MRI and determine the location of the white matter tracts and the relationship to the nidus. As such, you can do your mental operative execution. Having known the vascular arrangements, then you can define where the nidus is. You make a mental image of the venous and arterial poles that will determine your nidus, the number of veins, where you will find them, how would you access the main arterial supply, and the relationship to the overlying veins on the surface and deep. And then you have to proceed mentally to resect the nidus. Most of them is like an ice cream cone, not just a cone, with the initial part like an iceberg. So when your dissection initially comes from the surface, it has to go tangentially, not perpendicular to the surface. Otherwise, you will enter the nidus from the top arrows, as you can see, to the asterisks. And then the most important, to go around the deep part. So there are different ways Either you go circumferentially from superficial to deep, or as has been described by Professor Michael Morgan, to go to the nose of the cone. That means to go on one side, because the most difficult arteries to deal with will be the deep perforators. Even if they are not on angiograms, there will be arteries at the depths of the nose of the cone, and you have to deal with them earlier and then complete your resection. But all the time, whatever you're encountered around it are normal anatomical vessels, but structurally abnormal, but normal in location. So you'll have to encounter the cortical and subcortical vessels, the true perforators, and depending on the depth, either choroidal or subependymal vessels. And you will find superficial veins, but deep veins will be the transcerebral ones and subependymal vessels. Once you deal with the main feeders you see, never treat an AVM nidus as a tumor resection, because the difficulty are the very small vessels that are there or circumferentially around the nidus and feeding it, especially at the depths. So anatomically, we will talk about supratentorial AVMs, cerebellar AVMs, and to touch a little bit on deep AVMs that not necessarily should be operated on. So the blood supply that you need to know the anatomical angiographic pattern is to the lateral hemisphere, the medial hemisphere, supratentorial, fed by the anterior cerebral artery, branches of the carotid, middle cerebral artery, and the posterior cerebellar artery. Infratentorially will be the supracerebellar, ICA, and PICA. And the branches, mainly, the anterior cerebral artery gives a medial frontoorbital vessel, a frontopolar vessel, a pericallosal and callosomarginal. The MCA has two trunks as shown in the superior image. The superior trunk, which is the M2, is formed after the M1 already gave some branches. And one important branch to the lateral part of the inferior frontal lobe is the lateral frontoorbital branch. Then you have some branches that have different names, either prefrontal or fronto-opercular. Then you have a pre-rolandic vessels usually run in the precentral sulcus, a rolandic vessel, and from the superior trunk, it gives the anterior parietal artery. That means the superior trunk is feeding both the motor and sensory cortex. That's why deficit from here can be devastating motor, sensory, and speech. While the inferior trunk more anteriorly give anterior polar temporal branch, a lateral temporal branch, or posterior temporal branch of the MCA, and then it will give two branches. One will be the angular branch and the posterior parietal branch. And if you look carefully, there is always a branch that you don't see easily because it's small, but it's supplying the occipital lobe up to the primary visual cortex. That's why you get macular sparing with some PCA strokes. So the supratentorial compartment have these lobes: frontal lobe, temporal lobe, parietal lobe, occipital lobe, and they have different surfaces. And Professor Michael Lawton's book on the 7 AVMs demonstrates beautifully the location of different AVMs in relationship to the different lobes and their different surfaces. So your access to the nidus, you have to access, how to plan to access the cortical part of it and the deep part of it. And we will discuss how do you find the feeders, the cisternal parts, the cortical parts, the perforators, and the draining vein. So again, repetition again, the middle cerebral artery. So we'll start with the middle cerebral artery, terminal branch of the carotid, and the first branches you see will be from the M1, and that will be the temporal branches. So there is always a temporal branch from the M1 or sometimes the proximal M2. And this branch will come to the frontal pole, but also will go medially. This is a branch that you can follow if you are doing a trans-sylvian amygdala hippocampeectomy, because it will go towards the medial temporal structures. Then an important branch that we cannot see it filling on a lateral view, but on an AP, you can see them in the lower left illustration, which are the lenticulus striate. They are going back and entering the anterior perforated substance, which is situated adjacent to the carotid bifurcation. Then we have the two M2 branches, which are usually on the insula, as the image at the top left, showing an open operculum. And you can see the MCA over the insula, dividing in the two M2s. Again, for repetition, the proximal superior trunk of the M2 will give the lateral frontoorbital branch, which supply the lower part of the frontal lobe laterally up to the frontal pole. There will be some branches you cannot see here that are supplying the prefrontal cortex. They have to find their way in the sulci, because the sulci at this part are running horizontally, which are the inferior and superior frontal sulci, but there are a lot of branches that will go there and eventually supply up to the superior frontal gyrus. Don't forget that the superior frontal gyrus will also get supply from the anterior cerebral medially. So it's a watershed area. Then you will have a rolandic branch in the precentral sulcus and the central artery. Now, if you can see the asterisk, it is pointing to the pre-rolandic artery at the operculum. So the asterisk in the top left image is at the frontal operculum. You can see that the central sulcus is in continuity with the central sulcus of the insula. So this is at the area between the rolandic and pre-rolandic artery. On the AP view, the central sulcus is the most lateral part. So in the AP view, the inferior vessels are usually the anterior temporal. The middle vessels are the pre-rolandic and rolandic, and the central artery or the rolandic artery is the one that is marked on the illustration, and it has a curve or C-shaped. The asterisk is in the pre-rolandic artery, which again on the brain specimen is all correlated. Then the final branch will be the anterior parietal, which is going to the sensory motor cortex. The lower trunk from anterior will give the temporal polar branch, an anterior temporal artery, and then posteriorly can have another posterior temporal artery, but usually it gives an angular and a posterior parietal with a small branch going, as you can see, towards the visual cortex. Now the anterior cerebral artery, to superimpose your angiographic and cadaveric views on the lateral very easy to identify. The first branch coming from the A2 will be the medial orbitofrontal artery. So the frontal pole has on the medial side, the medial orbitofrontal coming from the A2, while the lateral one is coming from the MCA. Then you have a frontopolar branch to the frontal pole, and then the pericallosal will continue over the splenium, showed on the cadaveric specimen as a single asterisk, and the double asterisks are marking the callosomarginal. On the AP view, it is hard to tell which is which, but usually the pericallosal in the single asterisk is more medial on the midline, and paramedian will be the callosomargin. Now, the posterior cerebral artery is a supply to the supratentorial compartment. So the part that supplies the cortex will concentrate on after the P1 joins with the P2. So the P2 is running in the cisterna ambiens. As you can see at the base of the brain in the cadaveric part, this is where it runs, and it will give cortical branches. You don't see them very well, but it will give an anterior temporal branch, which is supplying the anterior part of the tentorial surface of the temporal lobe, a posterior temporal branch, which will supply the middle part of the tentorial surface of the temporal lobe, and then a temporo-occipital branch will supply the tentorial surface of the occipital and temporal lobe posteriorly. That's why when patients cone, the medial cortical part will look low density because of ischemia of these cortical regions. Then there will be, as you can see, a constriction at the AP view of the basilar injection. This is where the PCA will run behind the midbrain and run on the tentorial surface. And then it will branch into two main branches, one in the calcarine fissure, which you can see in the top left cadaveric specimen, and the parieto-occipital sulcus. You can see a Y arrangement of the sulci. This is where the terminal branches will lie. So we'll go into frontal lobe AVMs. So angiographically, they will be supplied by branches of the ACA and MCA, and the veins that drain them are usually towards the superior sagittal sinus, but also on the lateral surface, they will connect to the sylvian veins, sometimes through the vein of Tollard, and also there will be deep venous drainage, especially perisplenium and towards the periventricular extension. And there would be white matter tract that would be involved. So in summary, from the angiograms we have looked at, the lateral surface of the frontal lobe will having branches from the MCA up to the superior temporal gyrus, from the lateral frontoorbital branch, the prefrontal vessels, and they are multiple, as you can see in the lower left illustration, the pre-rolandic and rolandic. The frontal pole itself will have supply from both sides. On the medial surface, the medial frontoorbital branch of the A2 and the frontopolar, and on the lateral will be the lateral orbital branch of the MCA. Medially, and also including the superior lateral aspect of the superior frontal gyrus, will be supplied by the anterior cerebral artery, which will be the medial frontoorbital branch, the frontopolar, the callosomarginal, and the pericallosal. This is an overview of the frontal lobe, and this is to show you on the surface, the veins are more prominent than the arteries. And then on the medial side, there is the falx that is covering the callosomarginal artery. But also don't forget the deep structures that are most important will be the superior longitudinal fasciculus, and the deep or inferior part of it will be the arcuate fasciculus. The superior frontal fasciculus will connect widely the hemisphere. So you use your connectome, your function is affected. And if you disconnect your frontal lobe, so there is a horizontal part that goes from the frontal to the parietal and occipital lobe. It has an extension upwards through the superior parietal lobule, and then it goes around and goes down to the temporal connections. The arcuate fasciculus connects the frontal speech areas to the temporal speech area. So you can get disconnective dysphasias. And these are examples we'll go through on the lateral and medial frontal surface. So this is a common question. Then of course, this, you can see a prominent central or rolandic artery. So this is an eloquent motor cortex AVM that will take 1 point. It is less than 3 centimeters, will take 1 point. And it is draining to the superficially to the superior sagittal sinus, as you can see. So it is a Special Martin grade 2. It is quite amenable either for no treatment at all or gamma knife. Surgery has its risks. Combination treatment is not needed as you are adding complications. Of course, the veins are more obvious on the surface. So here's this AVM with the asterisks exactly showing you on the AP what the central or rolandic artery look like. And this is the correlation on the angiograms illustrations below. However, there is also some deep connection, and the deep connection is shown on the AP view, very faint extension, which can go towards the corona radiata as well. So it's not just cortical. So some of them will be related to the face cortical area, which again can recover. But if the deep extension going superior-medially, it will disrupt the corona radiata. And if your resection goes through this white matter tracts, then you will get a more devastating motor dysfunction. This is a left frontal AVM. Now the asterisk is around the curved part of the arteries. This is not the this is on the medial side. This is the opercular segment of the M3 segment of the MCA. That means the AVM is just adjacent to the frontal operculum above the sylvian fissure. Just looking from the angiogram, I can know the location from the AP and lateral views. It is supplied by the fronto-opercular branches, which will be running outside the sylvian fissure, going straight to the nidus, which is draining superficially. The frontal operculum is adjacent to the Broca's area. However, we learned from our oncology surgeons colleagues that this is no longer universally accepted, and most expressive dysphasia is due to deep connection of the motor areas and its connection, as you can see, to the arcuate fasciculus, which will be as superior to the limiting or circular sulcus of the insula. This is quite deep. What is the most superficial important white matter tracts just deep to the U fibers at the depth of the sulci. So the deep extension can cause dysphagia, which can be either affecting the motor connections or can cause a conductive type of dysphagia. This is another AVM. Of course, the MRI can tell you that it's pre-rolandic, and you can predict this will be the blood supply. And if you look at the blood supply, this is the case. It's again very near the sylvian veins. As you can see, some of the vein is draining down through the sylvian vein and eventually to an equivalent of a vein of Labe to the transverse sinus. Now the asterisk here is showing you lateral to the asterisk is the pre-rolandic vessel. It is not really C-shaped as the rolandic one. Now the difficulty with looking at angiograms from AVMs, because of the shunting, you don't see all the vessels. You see the one that is supplying the nidus more, so you become really sometimes uncertain. But putting everything together, then this is a pre-rolandic supply, and you know that this has three major arterial and venous poles. One of them, as you can see, is coming from superficial, but also deep connections to the pre-rolandic M2, M4 branch of the MCA. There is a temporal pole superiorly towards the superior sagittal sinus and inferior and posterior towards the sylvian veins. This is another example that the CT scan shows you already, but again, this is really involving very proximal the operculum side, and you can see the asterisks saying, you know, the circular pattern or semicircular indicating the M3 segment, and just distal to it, the very proximal M4 as the operculum, and you can see the different phases of this AVM. This is an interesting concept. These are two different AVMs. The superior row is one AVM, and the inferior row is a different AVM. One on the right, one on the left. They may look similar to you, mirror image, but in fact they are different. The asterisk on the lateral angiograms marks the silhouette or the line of the internal carotid artery. The one on the top, as you can see, the main nidus is lateral to the line of the interior carotid artery. So this is, yes, in the frontal pole, as you can see from the AP, but its main supply is coming from the lateral fronto-orbital branch of the MCA. So this is where you access it laterally. While the inferior one is mainly medial to the carotid silhouette or carotid line. So it's getting its main blood supply from the medial fronto-orbital feeder that is coming from the ACA. So for this one, if really was more complex and you want to access the feeding artery first early, then you expose the medial part of the frontal pole, which will need a limited anterior interhemispheric approach. Now, if you look at the MRI scan, there is no way you can tell which is which. This is another example of a medial AVM. And the answer to that for question A, yes, it is related partially to the left side of the superior motor area. So you can get an SMA syndrome with a transient postoperative mutism. It is draining to the superior sagittal sinus, but it is medially. Of course, it is not the vein of Trollard, which is on the lateral hemisphere. And again, this is located on the medial part of the frontal lobe, as you can see from the lateral angiogram, the dilated pericallosal and some contribution of the callosomarginal arteries. So these are the medial frontal AVMs, and you can see they are important white matter tracts. You can see in the lower left corner is going through the cingulum and distorting the corpus callosum. So the deep resection of the nidus can disrupt the singular bands, and this will cause a lot of behavioral problems potentially. On the sagittal MRI, the third from the bottom showed nicely the bifurcation into pericallosal and callosomarginal with the AVM nidus there. At the top, if the AVM is not reaching the supplementary motor area, but never mind, if you go lateral to it, you will disrupt another important white matter tract going from there to the deep cortical area, including the basal ganglia, and this is the aslant tract and causing speech problems as such. Okay, so here, this is to show you how is the relationship of a different medial frontal AVM, again, adjacent to the supplementary motor area on the right, so will not have a speech component probably. And it will show you its deep extension, but it will show you again the arrangements of the arteries and veins. This is relatively easy to identify the feeders, as the poles are anteriorly arterial and posteriorly venous. So you can disconnect it from anterior and leave the venous drainage till the end. Temporal lobe AVMs, again overview, they are mostly supplied by the MCA, but medial by the P2 branches I briefly mentioned before. And the veins can be quite complex on the lateral and basal surface, which will be the tentorial surface, going to the transverse sinus, on the lateral to the sylvian veins, and eventually either to the transverse sinus, the sphenoparietal, or through the connection to the superior sagittal sinus as well. And deeply, the basal part of the temporal lobe or tentorial surface is drained by the vein of Rosenthal and medially by the choroidal deep veins. The white matter tracts of importance will be the optic radiation and the upper connection of the superior longitudinal fasciculus and arcuate fasciculus. So in summary, the branches that goes to the temporal lobe from the MCA is the temporal polar, the anterior and posterior temporal branches. The first two can come from the M1 or proximal M2. The posterior temporal coming from the lower trunk of the M2. The temporal polar, of course, will go to the temporal pole, and medially, the posterior cerebral will give the anterior and posterior temporal arteries, and from the P2 segment in the cisterna ambiens going laterally, they will be crossing over the tentorial surface and then will go cortical and subcortical to this area. The lateral posterior choroidal artery will be adjacent to the lateral geniculate body and will enter the choroidal fissure of the temporal horn. The anterior choroidal artery can give some branches adjacent to the optic tract. The tentorial surface is mainly supplied by these branches of the PCA. This is again an overview of what we are talking about and showing the temporal operculum and the branches together with the white matter tracts of the optic radiation and arcuate fasciculus. This is a relatively difficult one, although it's an easy AVM. So you can see this AVM is supplied by dilated M1 proximal M2 branches, which are temporal. And it is draining on the AP slightly towards the vein of Galen through the vein of Rosenthal and more superficial. So this AVM is located in the temporal lobe, mostly on the lateral surface, a little bit on the tentorial surface. And the reason I say that, because the main nidus, as you can see, is lateral to the carotid. It is not related to the orbital part of the frontal lobe because the blood supply is mainly from the inferior trunk of the M2 that does not supply this part of the brain. And he has a venous drainage. As you can see, there is ossification of the deep galenic system. So if you look at this AVM, you can see the asterisk marks the carotid silhouette. If the AVM is overriding this and extending medial to it, then it will involve the uncus and medial temporal lobe. But because it's lateral, then it's not extending to the uncus and medial lobe. This is an easy to identify, again, from the inferior trunk, mainly from the anterior temporal artery on the lateral side of the hemisphere, and it's involving the middle temporal gyrus. What is important about that, although in the Spencer Martin it's non-eloquent, of course the deep part is very near the optic radiation. So the definition of eloquence is no longer depending on cortical look. This is another AVM, and you can see here the demonstration of the optic radiation with the Mayer's loop on the roof of the temporal horn. And you can know that it's on the lateral side of the temporal lobe. You can see here on the cadaveric specimen that the sylvian fissure is open, and you can see that the temporal arrangement, there is a polar part of the temporal lobe, which is anterior to what you can see a transverse gyrus, which is the Hesher gyrus pointing towards the atrium and would be below the location of the post-central gyrus. And then it will mark the planum part. So you can see this AVM is on the lateral hemisphere, inferior to the planum part of the sylvian fissure. And you can see on the angiogram, it is extending posterior to in the asterisk, just overlying where is the transverse sigmoid junction on the tentorium, but it's mainly extending to the lateral temporal lobe because its predominant blood supply is from the MCA. If it was going on the tentorial surface, there will be a major contribution from the P2 branches of the PCA. This is again an example which it shows you the circular parts of the lower trunk of the M2. So this is a perisylvian or temporal operculum AVM. On the right angiogram, where the asterisk is, which marks the line of the carotid, and its most temporal pole AVMs will be much anterior to this line. So this one is just in the middle part of the temporal operculum and the draining vein from the posterior inferior corner towards the transverse sinus. However, this AVM is predominantly on the third angiogram from the top, overlapping very much the carotid line, and again similar to the last one on the lateral part, and it's draining from the supplied by the temporal polar artery, and it's going to the temporal pole as confirmed by the MRI scan. This is a AP and oblique basilar vertebral injection showing the posterior cerebral artery. And you can see the blue dots marks where the end of the cisterna ambiens and the point where the PCA runs over the tentorial hiatus posteriorly on the tentorial surface, then medial occipital lobe to terminate into the calcarine and parieto-occipital branches. And you can see a large branch coming laterally, not medially, which is the posterior temporal branch of the P2. That means that this AVM, which is quite large, is mainly on the tentorial surface of the temporal lobe and extending to the lateral surface slightly. And it's draining, as you can see in the left angiogram, venous phase, early venous drainage to the sagittal sinus. So based on its location, we cannot see a draining vein to the vein of Labi, but it is a possibility because it's on the tentorial surface there. And the proximal feeders are on the superior surface of the tentorium because this P2 branch is where exactly will be found. Of course, it has nothing to do with the superior cerebral artery, which is infratentorial. This is a difficult AVM, which again looks the same. However, there is some medial extension and it's located in the parahippocampal gyrus and adjacent to the origin of the posterior lateral choroidal artery. So it's going to the temporal horn. And that's why there is intraventricular hemorrhage and hemorrhage in the parahippocampal gyrus. And in the lower angiogram, there is a blush coming from the anterior choroidal artery. So there is no doubt it's involving the choroid fissure. It is small, eloquent, and will have deep drainage because the choroidal veins will go to the vein of Rosenthal, and so it will be a special Martin grade 3. This is based on probability rather than what we can see on the angiogram. Again, we don't use for question B embolization unless they are really necessary because we are adding complications to surgery. And the nidus is located at the parahippocampal gyrus and adjacent to the choroid fissure as described. And in this location, because there is a hematoma, they are providing you the corridor before the hematoma disappears. You can approach it through this hematoma a week or 10 days later, and it will give you access to the nidus, or alternatively subtemporary or even transsylvian. And it is probably draining through the vein of Rosenthal, although we cannot see that. So these are examples that discusses the tentorial temporal lobe, and you can see here what on the illustration of the cadaveric specimen. On the left, the branches of the P2 as the tentorial hiatus and the branches going to the choroid fissure. On the right, the open choroid fissure extending into the temporal horn. And these are the AVMs discussed. This is another tentorial AVM showing you the same principles, and you can correlate the angiograms with the MRI, but what is different in this one that it has equal distribution, not equal distribution, predominant supply from the PCA, even in the carotid injection, the region Y is filling because the posterior communicating artery, as you can see, is quite large and going through the P2 to supply it. So this is a true tentorial surface or extending to the tentorial surface, temporal AVM, rather than lateral surface. This one we have already been discussed in the question, but it's a more clearer magnified image, types of the nidus. Here are the branches. Again, to summarize, the upper trunk will give the anterior parietal branch, while the lower trunk will give the two branches, the angular to the inferior parietal lobule and the posterior parietal. While medially, again, the continuation of the callosal-marginal and pericallosal will go to the paracentral lobule, which will be the medial part of the sensory cortex, while the PCA distal branches will give the parieto-occipital branches to the medial superior parietal lobule, and there is an important small branch that we don't identify easily on angiography, is the splenial artery to the splenium of the corpus callosum. The left supramarginal gyrus is a part of the inferior parietal lobule, and you can see that is just adjacent to the Sylvian fissure. So this is the parietal operculum. And the cortex is eloquent, but the deep connections, as you can see from the arcuate fasciculus, but also the SLF from the frontal, going in the depths, in the white matter of the inferior parietal lobule, has a lot of connection to do with speech. And this deep resection of this AVM can cause more significant speech problem, not just in naming. And you can see on the angiogram, this is the terminal branches, which with the asterisk would be the angular branch of the lower trunk of the M2. This is the parietal AVM in the paracentral lobule because it's supplied by the terminal pericallosal artery. You can see some perinidal changes, which is quite prominent on the left angiograms, which is the terminal branches of the posterior cerebral artery and the parieto-occipital artery. So this is AVM in the paracentral lobule, and it's all medial, so you don't split the Sylvian fissure, obviously. And the perinidal cells, that is more obvious in this magnified view, will make the surgery more demanding to identify the limits of your nidus. Again, this is the supply from both sides, from the MCA and distal ACA, showing a larger paracentral lobule AVM that is in fact extending to the superior parietal lobe as well. Now this is an AVM that is involving the medial parietal lobe, but going near to the splenium. And you can see in the lower right angiogram, the asterisk showing a C-shaped superiorly running small splenial artery, supplying this splenial AVM with extension to the medial parietal lobe, with blood supply from the anterior cerebral, distal pericallosal and medially. And on the third angiogram from the bottom, the parieto-occipital branch, terminal branch of the PCA. So the splenial artery, pericallosal artery, and the parieto-occipital artery that's supplying it. The occipital lobe is mainly supplied by the PCA, as you know, but I did mention the branch from the MCA to the primary visual cortex, and it has lateral surfaces, medial surface, and tentorial surface. And the most important deep structure, of course, is the determination of the optic radiation and the eloquence of the primary visual cortex itself. The blood supply is mostly PCA from the distal terminating branches in the calcarine fissure called calcarine and the parieto-occipital sulcus called parieto-occipital, as you can see in the angiogram illustration in the bottom. The most important ones are really the medial ones, and of course the MRI really is useful here to show you how far it is from the primary visual cortex. But when you resect these AVMs, it is very important to be aware that some of the arteries that you see involved will be on passage and ending into the primary visual cortex, and these are very important to spare. Again, a different one, quite larger in the cuneus, and you can see from the lower right angiogram, it is pointing inferiorly from the PCA towards the calcarine artery, and if there is parieto-occipital, then it's supplying the cuneus inferiorly. While this one is on the opposite, in the lower left angiogram, it's superior to the PCA, and it's in the precuneus. So this is not really a predominant occipital, but it's a predominant parietal, but nevertheless, it is near the visual cortex and has to be treated with respect. This angiogram showed a basilar injection, lateral, and of course you can see that the asterisk showed a dilated ICA. So this is supplies the petrosal surface of the cerebellum. So this is a cerebellar AVM. It has a lot of draining veins that are quite wide. So there is no particular risk of hemorrhage from this stenosis because it has a generous venous outflow. The ICA will be related to the 7th and 8th nerve, as in Rothen's rule of thirds, where the trigeminal will be more superior, related to the superior cerebellar artery. And as you can see here, the same patient MRI scan, it's in the petrosal surface of the cerebellum and flocculus. And on the left, you can see the ICA loop with the pre-meatal and post-meatal vessels and a dilated loop around the 7th and 8th cranial nerve complex. So as the rule of third shows that these are the three major branches in the CP angle, but then you have to know for the cerebellum, it is the cortical distal branches that are important. These are the surfaces and components on the MRI of the cerebellum. So the suboccipital surface is the one that you exposed with your craniectomy. And what you see on it is the tonsils and the suboccipital surface. This is supplied mainly by the last segment or cortical branches of the pica coming around the tonsils and supplying the suboccipital lobe and going medially up to supply most of the vermis. The tentorial surface is the largest surface and is supplied by the superior cerebellar artery, SCA, and this is the major contribution to the cerebellum because it's the largest surface and a little bit on the suboccipital. However, medially in the midline, the superior vermis is getting contribution from the pica. The petrosal is a very small part of the temporal of the cerebellum, including the flocculus, and a little bit of the anterior surface of the tonsils, and it's supplied by the ICA. Here are the surfaces, the suboccipital, the tentorium, and the petrosal surfaces. So here is the vessels, and you can see the segments of the pica and ICA. So if you look at these images from Rothen's dissection, you can see that the ICA coming from the vertebral, it has a lateral medullary loop with an anterior and lateral medullary segments giving perforators to the anterior lateral medulla. and then goes around the tonsils and then the cerebellum. The ICA, you can see both sides here with a premeatal loop with the apex giving the labyrinthine artery and returning back postmeatal to end in the flocculus and giving cortical surface to the cerebellum, while the superior cerebellar artery at the top, giving the cranial and caudal branches, supplying distally the cortical surface of the cerebellum and the dentate nucleus. This is the anterior view showing the petrosal surface with the ICA loop related to the 6th nerve initially, and then the loop around the 7th and 8th nerve, while the pica in the bottom, going up anterior medullary and lateral medullary loop, giving perforated to the medulla, with the apex as high up as the jugular foramen, while the superior cerebellar artery at the top, with close relationship to the 5th nerve. This is what it looks like on the angiogram, with the ICA readily filling and the two loops on the lateral view of the pica, one around the medulla and one around the tonsil. These are the segments of the pica. There are 5 segments, the anterior medullary and lateral medullary segments, with the first asterisks on the angiogram show the bottom part of the medullary loop, and then you have a tonsillomedullary and the tilo-tonsillar segments with a loop around the tonsils with the other asterisks, and you can see a flow aneurysm just distal to it, supplying a distal cortical small AVM nidus. These are examples of superior cerebellar artery supplied AVM on the left, while on the right you have a petrosal AVM. You can see the different patterns of the angiogram. The feeder is from superior cerebellar artery and ICA on respectively. The superior cerebellum is the major part, but again, you may get a contribution from the pica if it is going paramedian, because the superior part of the vermis may still get a contribution from the pica itself on the midline. This one we have already discussed in the petrosal surface, but again, you can see how the nidus is near the basilar on the lateral view, which similar to this one on the lateral view rather than the oblique, which shows that this is usually indicates it's in the petrosal surface, but the giveaway is that you can see a prominent ICA, which we're not normally seeing, which is predicted to supply this area. As we said, it is normal vascular anatomy. And this is a similar one with a contribution from the pica, indicating that it's more inferior than the petrosal surface and involving the tonsil as well, because the pica cortical surface are mainly vermian, suboccipital, and tonsillar. Finally, deep AVMs are important to recognize, mainly to avoid operating on them if you can. They can involve the basal ganglia and internal capsule, the thalamus. They can go to the brainstem or ventricles. They involve the white matter tract. Here is the angiogram in the bottom, showing the asterisk to show you how dilated is the distal lenticular striate, not just going to the internal capsule, but in the coronary radiata. And you can see in the CT angiogram that this is an AVM involving the coronary radiata with a hemiplegia from the hematoma. Again, the insula is supplied by M2 branches, and at the top row of the angiograms, you can see complex AVM, but if you see where the blue arrow is on the AP, it is medial to the M1. That means it's involving the insula. If it is lateral, then it will be in the Sylvian fissure, because you can see on the cadaveric specimen, the insular surface vessels are on the sulci of the insula, on the short and long gyri. This is important to recognize the flame-shaped appearance, which is typical of supply to the thalamus. So this is an AVM in the thalamus. It is supplied by thalamoperforators, and on the lateral, geniculothalamic perforators. So this AVM is not in the cerebellum at all. It is in the thalamus. And of course, no AVM, even if it is in the occipital lobe, will be approached to the calcarine fissure unless the patient is already totally hemianopic. So the thalamic arterial blood supply, as you can see in the cadaveric specimen, from the anterior P1 and basilar artery going through the mesencephalon, because the thalamus and the midbrain are attached together structurally, and the anterior thalamic perforators, where the asterisk is on the lateral angiogram, and then more posteriorly from more lateral P1 and P2 segments are the posterior anterior thalamoperforators, where the vertical arrow is. Then the thalamus is a quite large structure. The posterior choroidal artery gives geniculate perforators, and also from the P2 medially, and these are called the thalamogeniculate perforators going through the lateral surface where you have the geniculate bodies, where the horizontal artery is. So this is an AVM of the thalamus itself. So in summary, angiographic anatomy is important, but don't forget that simple AVMs do not require all this, but you need to have the knowledge to tackle more difficult AVMs. You have to know brain anatomy, not just vascular anatomy, the same as low-grade glioma surgeons. You know your white matter tracts, and because an AVM surgery is operating in the brain, sometimes we can make surgery easy when we have a big hematoma, because when you have a big hematoma with increased ICP, you try to avoid doing surgery. A lot of them do tolerate them, but if you cannot really control their ICP, then you can consider just doing a decompressive craniectomy. However, if you have an angiogram and the AVM is quite small, then you can remove it in the acute stage, but we do not recommend to do this for more complex AVMs. However, if you have a large hematoma, you can take advantage of it before it disappears and resolves, because it can help you if you can wait in the subacute stage and use the hematoma to facilitate resection. There is some concern because perhaps your nidus is really less obvious with the presence of the hematoma, but what we have looked at is our experience in surgery with hematomas. We have a relatively large series. We use the hematoma cavity to take you to an AVM. If it's simple like this, you don't have to go subfrontal on the left, but the hematoma cavity, once you wait 7 days, 10 days, become liquefied, and use it as a trajectory, which will take you to the AVM, which even can be as deep as the periventricular one in an eloquent area as this one. These are other examples, including the one I showed you already in the parahippocampal gyrus. Sometimes the hematoma can dissect the deep structures, such as this another insular AVM, which has already disrupted the insula and pushed the internal capsule laterally. It facilitates the deep resection, and you can remove an insular AVM of this appearance with relative ease, and you will not add morbidity, but be careful in cases that the hematoma has not dissected it completely, because some perforators can induce a new deficit. They can be used to displace white the tracks as in this one. There are ones such as the optic radiation, but this one adjacent to the caudate, quite large, but the hematoma has separated the deep surface of this basal AVM from the caudate nucleus. In the cerebellum, the hematoma tends to be well to localize the nidus because a lot of them, the nidus is small. So you can use your hematoma to facilitate removing AVM. Avoid pitfalls. Don't do it without an angiogram because if it's a dural AV fistula, the procedure is quite different, but it's outside the scope of this talk. In selected patients, liquefying AV hematomas can facilitate and make you plan AVM easily. Don't forget the common pitfalls. All feeders are main feeders. You have to respect the deep ones at the deep surface, the perforators. Perinidal vessels are difficult and it needs a lot of experience with the ones of very prominent perinidal vessels. Do not underestimate these cases because it's very difficult to define the nidus, and consider all feeders potentially as en passant until you dissect them fully. This is again example of hematomas, of AVMs that have two compartments. This one from filling partially from posterior circulation and partially from anterior circulation around the corpus callosum and so on. This is again to show you that these arteries remodel after resection of AVMs. They may be dilated for a while, but they return back and they will look structurally normal, and you will discover that they are all in normal location. An AVM does not have abnormally anatomical vessels, but structurally it may be abnormal. So in conclusion, your normal vascular anatomy is the key for AVM surgery. Don't forget your white matter knowledge. You have to have knowledge in every aspect of brain surgery, even if you are a vascular neurosurgeon. And always be prepared to have the 3D vision and attack AVMs, but don't forget the simple one are so simple. And finally, to leave this with you, just for time's sake, this is an orbital AVM. You can see it is a large ophthalmic artery giving anterior ethmoidal branches within the orbit because it has not gone to the anterior fossa, because the venous drainage on the right is through the superior ophthalmic vein. So it's an AVM the orbit. And thank you very much for listening for all this time. Thank you.
Great. Thank you very much, Dr. Kyroulos. We're just waiting until Ahmed is going to turn on again the. Ahmed, are you there? Can you? Do we have time for questions? Hi.
If Dr. Ramos can switch on the camera.
Yeah.
Yes, I'm pressing.
Mr. K, yeah, if you can also switch on your camera, that'll be great. Thanks very much. As I say, I think this was a fantastic talk, even though it was quite long, but I think you covered pretty much everything in terms of the anatomical basis for AVM surgery. So thanks again. This was also live on YouTube, and it'll also stay on YouTube forever. So, you know, people can go back and look at it at their free time. Mr. Kyroulos, is there anything that you might want to say in summary, or shall we take some questions first?
I just picked up one of the comments about using microcatheters to find the feeders. I suppose these are not commonly done. These are the radiologists only use selective angiography when they are planning or exploring whether they can embolize them. But normally we don't get these views. They are, of course, excellent. They are That's why it's best for surgeons to watch radiologists doing it, because it will tell you a lot to learn from them about the angiographic anatomy. But again, when you do AVM surgery, all the main feeders are not the problem. These are not the problem. You control them, you find them, but still the small ones, as you dissect, becomes more and more difficult. So knowing the main feeders are good to define your nidus. They are good to show you the limits of your dissection and how far to go, but the main difficulty are the small feeders, especially the deep ones.
Okay, I think actually Dr. Al-Jahani, who asked this question, he's actually, I think, a hybrid neurosurgeon who's doing endovascular and open surgery. So I guess, you know, this is why he's getting these views, because he can do it himself.
Yes.
Dr. Al-Jahani, did you want to, I think you've made a comment, yeah, and yeah, this is what you say, that you're a GL-trained neurosurgeon. Yeah, thank you very much.
Yeah, so, you know, never subspecialize your knowledge. If you are a surgeon, you have to know angiographic anatomy the same as neuroradiologist. You have to know brain anatomy as a glioma surgeon. You subspecialize your practice, but your knowledge, you should know everything. You know, the same like even if you do craniocervical junction, even if you're not a spinal surgeon, you have to have some knowledge of that. This is the whole message of knowing white matter tracks as a vascular surgeon.
Fantastic. Any other comments that you want to make, Mr. K?
Again, this talk is mostly anatomy, but don't forget a lot of AVMs are much easier to do like that. The whole idea that your surgery should be very simple. If there is a technique that only few people can do in the world, it's not worth learning. For neurosurgery to survive, all operations have to be technically simple enough for everyone to do. In Africa, in Asia, in America, everywhere. And the way to do it, the more you know anatomy, the simpler your operative techniques, and not to make drama out of it. Simple AVMs are easy, you just go around them, you remove them. Talks like that, it's not only to encourage you to take more difficult AVMs, in fact, to encourage you to not underestimate the task you're doing. So sometimes if you know more, you will do less operations. So it's not always a glamour exercise.
Great. I think these are some very valuable comments that you're making. Can I ask, I don't think that we have any questions at the moment. Can I ask a question, Mr. Kyroulos? Obviously, you know, a few years ago, we had the publication of this randomized trial, the Aruba trial. I know that many people have published editorials and comments criticizing the study. And obviously, there are quite a few issues with the study. What is your view on the study itself, but also your view in terms of how we can move forward the field of AVM surgery as neurosurgeons?
Well, the study, during the study, the reason why the study came, because originally there was a claim that unruptured aneurysm, the risk of annular rupture is very small. It's always almost 1% or less. Now, in the Aruba study, the valuable part of it that this was not true. The unruptured AVM, they can rupture between 2 and 3%. So this was one aspect out of it. It was good to tell people if you are very good in your work, you know, when it comes to incidental lesions, you have to be careful. These are prophylactic treatment, and you have to be very good in your results. Nevertheless, all of us know that the Aruba study mostly showed morbidity from endovascular rather than surgery or gamma knife. So not many people pay attention to it as much as before.
And in terms of I mean, how can the field of AVM surgery move forward in terms of future research? Do you have any?
Oh, future research, I think the difficult ones, the results from gamma knife and stereotactic radiosurgery are quite good. The problem is delayed effect for the ones that presented with hemorrhage. Perhaps one of the scientific fields is to find markers or genes or radiosensitizers, things that will allow AVMs to be more radiosensitive and obliterate earlier. This is a part of basic science. As regard the surgery, then I think the planning models, the anatomical models, are getting quite well using tractography. But I think the instruments has to be advanced in the whole field of neurosurgery to make surgery easy. Look at general surgery, how people used to do anterior resections with sutures and anastomosis. Now you have staplers. So many people can now cure colonic cancer. So the same, you cannot allow neurosurgery to have so sophisticated techniques that only few people can do. You must find ways to make bypass surgery easy, instruments that makes operations available to everyone.
Thank you. That's I think that's a very valuable answer again. Any thoughts that you might have, Mr. Kyroulos, in terms of the registries that many people are thinking of setting up? I think I've been to a few meetings now that people talk about registries. What are your views on the registry?
The registries are good. There are two aspects of it. For AVMs, it's the ones that are not treated. You have to get the data for. Now, the problem, how to make a registry. The registry are good to register the cases. Now, if you make it so comprehensive, it is very difficult to put all the data in. If you make, and again, if the data is not enough, then it becomes meaningless. So sometimes there must be at least a question the registry is set to answer rather than gathering everything. But this is a general problem for all registries.
For all registries, yeah. Fair enough. Any questions, Dr. Al-Ahmari? Any questions that you might want to ask?
Yeah, it's a great topic and great preparation for a few days prior to the presentation, being contacted and checking the content and everything. Thank you very much for your contribution.
Well, thank you all for listening to such a long, boring time. I'm sorry, it was too long. Sorry.
No, not at all, Mr. K. I think we've had some very good feedback as well on the chat of this talk. So we had very good feedback already. Thanks very much for your time, Mr. Kyroulos. I know that you put in a lot of time into this, so thank you very much.
Well, thank you
it was a fantastic talk, and have a good rest of your Sunday.
Okay,
have a good,
thank you very much.
Yeah. And we'll come back in November with the next webinar. The title will be shortly announced. So thanks very much, everyone. See you later on. Bye.
Thank you very much, everyone.
Okay, bye.